Good morning, teachers, friends, and colleagues. So what's new in the smallest branch or subspecialty of orthopedics, which is pediatric orthopedics? So since I have 5 minutes, I thought I'll cover the top 5 advances that I felt really made a change in how we practice over the last decade or so. And I'll go through each one of them in some detail. I think what has really changed paradigms of treatment in long bone fractures in children is the innovation which has come from Nancy in France, which is the elastic stable intramedullary nailing system using titanium elastic nails. Not only in the femur, tibia, but also in the forearm. It's a minimally invasive technique which preserves the biology and rapid healing that is seen in children. It maintains alignment, so less risk of a malunion, provides fair stability for lesser immobilization, and we've seen a faster recovery to school and sports in children, thanks to this innovation. The second biggest trend that I see, which has really changed the way we treat angular deformities in children, has been this very innovative technique came out from Peter Stevens in USA, which is the growth modulation, which harnesses the power of growth to correct deformities in children. And here's a child who has an idiopathic genu valgum of around almost 15 or 20 degrees. At some time, this would require an osteotomy. But because of the 8-plate fixation and the use of growth modulation, within a span of 14 months, this deformity can be entirely corrected with a very simple and elegant technique. And anyone who's still a skeptic, I can present you this very powerful technique of growth modulation, where you can see this child with hypophosphatemic rickets with the O deformity of the femur and the tibia, with an intercondylar distance of almost 10 inches. And this was our very first case of growth modulation. We had just read the paper by Peter Stevens. The 8 plates not even available in India at that time. We used a simple 2-hole plate, first in the femur and then in the tibia. And you can see in a span of around 4 to 5 years how this entire deformity was corrected without requiring very complex osteotomies at multiple levels that we would have done many years ago. The third innovation I would feel that has really changed the way we do things in pediatrics is why should adult orthopedic surgeons have all the fun? They have a lot of different specific implants that they use for various bones and various regions of the bones. And it's only in the last 10 or 20 years that we now have pediatric specific implants, both for the proximal femur and the distal femur as well. So here's a child with Perthes stage 1B, and this is a standard femoral varus osteotomy that we used to do normally using a lateral plate. But now with the advent of these pediatric proximal femoral LCPs, we can now fix these really well, maintain the biomechanics of the hip as it was meant to be, create the sufficient medialization, rapid mobilization, and return to school and sports very soon. And that's a longer follow-up of the same child who's now skeletally mature, and you can see perfectly well-rounded hips that should last a lifetime for this young child. Similarly, in the distal femur, we have a similar implant. We use the same principles of very advanced techniques of crouch surgery management, doing a distal femoral extension osteotomy and a patella tendon advancement. Here's this young boy who could barely stand and walk before the surgery, was in severe crouch, and with this powerful technique of using a distal femoral plate fixation, avoiding the need for plasters and prolonged casting, this child can now walk extremely well as a community ambulator. I would be remiss if I did not mention one of the biggest advances that we have is understanding the vascular supply of the proximal femur. Excellent work done by Professor Reinhold Gans and his group from Bern, which have shown us that because we now understand the vascular anatomy of the hip, we can now open the hip safely, dislocate it surgically, with very low risk of complications of AVN. That opens up an entirely new vista of various intra-articular procedures that can now be performed around the hip. Here's a young boy with a grade 3 slip. Many years back, this would be treated with an in-situ fixation with very poor results. But now understanding the anatomy of the proximal femur, understanding this powerful technique of surgical dislocation, we can now go ahead and do a capital realignment procedure, and this child having a good result at long-term follow-up. The final innovation, I would say, is for a very age-old problem that was one of the biggest bugbears of pediatric orthopedics, which was the congenital pseudarthrosis of the tibia. And various techniques have been devised over the years, but I would say that with this new technique of cross-union, achieving a synostosis between the tibia and fibula, work done initially from Korea and then independently by Rod Paley, we can now ensure almost a 95% success rate in this very difficult condition, which at times, well, the only treatment used to be amputation. So this in a nutshell, friends, is the 5 innovations that I feel really changed pediatric orthopedics over the last decade or so. Thank you so much for your attention.